Good morning, everyone, or afternoon, depending upon your time zone. I want to welcome you to Virginia Garcia's 2025 Healthcare Symposium, Driving Community Care, Mobile Health in Action. My name is Gil Munoz. I'm the CEO of Virginia Garcia Memorial Health Center, and it's my honor to welcome you all to this year's event. Each spring over the last 16 years, Virginia Garcia has brought together healthcare and community leaders from across the region to discuss important topics in community health and primary care. Over the years, the symposium has focused on a range of issues, including the transformation of primary care in the patient-centered primary care home, the use of teledentistry, and the impact of adverse childhood events and toxic stress on the health of our population. 15 years ago, we held our symposium just days following the passage of the Affordable Care Act. Governor Kitzhaber spoke at the symposium on the significance of this legislation. This momentous change to health policy, which extended Medicaid coverage to millions of low-income individuals and protected people from losing coverage from pre-existing conditions, is again in the national debate. Will Congress maintain support for Medicaid or seek other budget priorities? The repercussions could be devastating to our efforts to ensure coverage, to promote a patient-centered primary care home, to advance the quintuple aim of improved outcomes, patient and staff experience, lower total cost of care, and addressing health equity. This annual event brings people together across health, education, government, social services, and business to discuss the key issues and innovations in healthcare. Along with bringing to you experts in the field, the symposium welcomes your questions and comments. Through our dialogue, we continue to improve our understanding and strengthen our services moving forward. This is a special year because 2025 also marks the 50th anniversary of the founding of the Virginia Garcia Memorial Health Center. 50 years ago, the founders of this organization began a mission of overcoming barriers to access for the farm worker population, as well as others in the community. We remain steadfast in this mission today. Our focus for this year's symposium on mobile health also directly connects with the origins of Virginia Garcia. Since our founding, there has always been a mobile outreach program to serve our agricultural workers. 35 years ago, when I started, that looked quite a bit different from what we have today. In those days, we had a small trailer known as the burro that was hauled around to the camps to serve as a makeshift exam room. Later, we collaborated with Northwest medical teams to provide their mobile units to the fields. Today, Virginia Garcia has its own small fleet of units that are tending to the fields and beyond. The program continues to develop and adapt to the needs of the community. During the COVID pandemic, our mobile unit was throughout the community, in church parking lots, schools, and housing complexes, testing and vaccinating the population. The crisis of the pandemic was also a time of rapid innovation. We saw the importance of partnering with public health and community-based organizations to make our mobile health programs even more effective in reaching the most vulnerable populations in our service area. Today, we build on that knowledge and experience, and we look forward to employing our mobile health program in collaboration with community partners to meet the ongoing health needs of our community. It is now my pleasure to invite Jamie Sewell from CHP Group, our presenting sponsor, to say a few words.
Good morning, and thank you. We are grateful for the opportunity to be the presenting sponsor today. By way of background, the CHP Group is a third-party administrator and a network for integrative healthcare providers, including chiropractors, naturopathic physicians, licensed massage therapists, and licensed acupuncturists. We're a proud sponsor of Virginia Garcia and have been for many years. CHP sees the importance of the legacy of Virginia Garcia and are pleased to be able to honor her. The health services that are delivered by Virginia Garcia to underserved populations fills critical needs within our communities. As we continue to be challenged by access to care issues, mobile health provides opportunities for care for those who may have impediments to transportation or other social determinants of health. CHP, as a facilitator of healthcare services, it's important to us that communities have access to essential health services. The continued partnership between our organizations upholds a shared commitment to advancing equitable access to healthcare services, collaborative approaches to addressing evolving healthcare needs of diverse populations, and of fostering healthier communities. Since our founding in 1989, the CHP Group has become a leading authority in delivering accessible and high-quality integrative healthcare solutions that promote health and satisfaction while managing the rising costs of healthcare. We're proud to be here today and to introduce our moderator, Dr. Ava Galvez. Dr. Galvez is a site medical director at Virginia Garcia Memorial Health Center, and she'll be guiding us through our discussion today.
Thank you so much, Jamie. Now it's my honor to introduce to you our keynote speaker, Dr. Jim Withers. Dr. Withers is the founder of the Street Medicine Institute. Dr. Withers' pioneering work in street medicine started in 1992. It was then that he joined a formerly houseless man to make house calls to street dwellers in Pittsburgh. This initiative led to his groundbreaking work with Operation Safety Net, the street medicine program he established and continues to work with in Pittsburgh. In 2005, Dr. Withers established the annual International Street Medicine Symposium, now with partners all over the world, to foster collaboration and the care of those sleeping on the streets. In 2009, Dr. Withers created the nonprofit Street Medicine Institute to promote the global practice of street medicine. He then went on and created the first Street Medicine Fellowship at UPMC Mercy Hospital of Pittsburgh. Since its establishment, Street Medicine Institute has become the global leader in developing the field and practice of street medicine and has helped cultivate and improve street medicine programs in over 140 cities in 27 countries across 6 continents. And if this were not enough, Dr. Withers is in practice with the Pittsburgh Mercy Health System on the internal medicine teaching faculty of UPMC Mercy Hospital and also an assistant clinical professor of medicine at the University of Pittsburgh. Dr. Withers, welcome.
Thank you. Thank you very much. It's an honor to speak to you on this occasion and to this wonderful group through this wonderful organization. If I can, I'm going to try to share my screen. Looks like there's hope. Okay. Sorry, folks. I'm hopeful that it's showing up now. This is, I'm going to talk about street medicine, but I'm hoping to connect with you all on the shared common values that I know we have. The tagline there, the title is the tagline of the Street Medicine Institute, and it's "Go to the People." This is something I saw on the wall of a hospital in Haiti, and it just seemed to capture so much of what I was seeking to do, to be, to promote in my my career in healthcare. That picture in the front there happens to be a younger me working with old John. He was on the streets there in Pittsburgh in the early 90s. The symbolism of that stance I've seen much more often in the wonderful volunteers, nurses, and PAs that we work with. But I'm going to come back to that image because it is relevant to our institute and our movement. This is what I like to call real Dr. Withers. This is my dad. He was a family medicine doctor. My mother's a nurse, and I made house calls with him in rural Pennsylvania. And so a lot of that notion of going where people were, honoring them, respecting them as they were, I kind of came by naturally. My parents, my dad was actually inspired by a Life magazine article that he read of a doctor who in rural Colorado who was visiting people by horseback, by walking, and so there's a kind of a chain of thinking there that goes back long before me. I will say that in my teaching career, I grew up in rural Pennsylvania, but working in an inner city hospital in Pittsburgh really expanded my mind and imagination about the social context of people's health and their lack of health. This particular gentleman, all photos I'm using were with permission. This particular gentleman was not the one that the story starts with, but they actually bore quite a resemblance. I had a man come into my hospital inpatient service in a bitter cold of winter, and I just met him, and he was already insisting on leaving the hospital. Despite my best efforts, he chose to leave, and unfortunately, I learned that he froze to death. I was hearing lots of negativity from staff and my colleagues about all kinds of populations. In this case, I heard someone tell the joke, what do you call a frozen homeless guy? And the answer was bumsicle. And it was at that point I realized how callous and dehumanized we had become, not just in how we were treating people, but in who we were becoming ourselves. And so I thought, well, the classroom that I need would be under the bridges of Pittsburgh. And so honestly, my journey into the street was not because of anything, anybody that particularly needed me on the street. It was, I needed them, if they were willing to open their lives, to teach me what their lives were about, their strengths, their struggles. And I've been very, very blessed now for 33 years to have people in Pittsburgh and other places graciously allow me to come into their lives and share their journeys. So this is my classroom of the streets. I think it's always important to have someone with lived experience, and this was my friend Mike. He's still my friend, but he retired. He spent 7 years experiencing homelessness and made a deep impression on him. And so when he returned to Pittsburgh, he began to work with agencies, going out under bridges and giving blankets and food to people. Ironically, most of those agencies did not want him to go under bridges. They wanted him to go to congregate sites and places where the numbers could be counted and they could keep tabs on him. But Mike and he was exactly the person I was looking for. And so, as you guys know, it's important to respect those that the people respect and to find those partnerships, those natural alliances. And so I became the tag along here of Mike. Here I am trying to dress what I thought was appropriately for street rounds in the early days. And so Mike began to take me out under bridges at night, into abandoned buildings along the riverbanks. And I was utterly amazed at how many human beings were sleeping in dire circumstances. They were a very heterogeneous group of wonderful human beings, suffering greatly. And many of my own stereotypes and preconceptions were just blown out of the water. But it's exactly what I wanted, was a chance to start myself and my thinking from a new, fresh place, in which the power dynamic was not the overwhelmingly dominant part of the relationship building. What I found were that there were many people, as I mentioned, who were receiving, or not receiving, I should say, healthcare. This gentleman here kind of typifies the juxtaposition of health and homelessness, and the exhaustion. And not to pick on the guy there, but those of us who turn our backs on him. A little bit about homelessness. This is Dennis Culhane's study from some time ago, but I think it still holds true, or at least it has held on a little bit. Most of the folks who experience homelessness are not homeless very long. They use only a third of the health systems and the city's resources. But there's always that 10% or so who suffer the most, and also consume, if you will, many of the system's resources, just due to the fact that their needs aren't being effectively met. I would say they do not receive reality-based services. They have services that they are welcome to go try to use, but they don't fit where they are, and that's key. But it's always the individual. Tracy here is long gone, unfortunately, but I like this photo because of I knew Tracy. I was very privileged to get to know her much better than I did when I first met her. She had a very difficult and traumatic life. She had so much strength and courage to stay alive, and generally to make other people's lives brighter when they met her. I like to show this photo because the little girl in the picture kind of symbolizes for the person inside of us that can still actually see people, who still has compassion, who empathy, and has curiosity even about who she might be. Whereas for the most part, those rough sleepers and others, on the street are not even part of the community from most people's opinion. What I learned is that there are new ways that people survive in their own communities. They build community. Sometimes it's pretty rough, but it's extremely loyal, because they're like veterans from a war. They know each other. They know that they won't be shamed and blamed. That if you really need a blanket or some other thing to get by, it's the folks that live in the same circumstances they're the ones that are most likely to just be there for you. What I found after being on the street for a while, this is M.C. Escher's, one of his drawings. I don't have my goatee anymore, but it might have resembled me a little bit more in the past. But it's looking back into the system, looking at yourself as a member of that structurally violent system. And when you are closer to where people are, and you gain solidarity, you begin to, pardon my Spanish, but you're not just in la calle, but you're de la calle. You become part of the street, and you begin to see the ugliness and the and hypocrisy and sometimes just the insanity of what the system looks like. So educationally, it's really powerful. This is my friend Skeeter way back when. This photo just kind of symbolizes that even though the folks in the street said, I'd rather die, I heard this today, I'd rather die than go to the emergency room. I'd rather die than go to the hospital. when they realized that I was a physician and I began trying to do what I could, I've never received so much love from people as I have from those living on the streets. It makes me almost want to cry thinking about it. But there's a need for reconciliation, and you guys know that. But there are people, groups of people who have been treated wrong, and we owe them reconciliation, and we owe them respect. Speaking of respect, this is was my friend George. He was my street professor of the concept of respect. I love George because he did not compromise. I guess I can say it. He didn't kiss anybody's butt, and I loved him for that. He taught me his loyalty to the others out there. Eventually, his loyalty to me. But the spirit that could not be crushed. He'd been to Vietnam. He'd been through a lot of things, and so I'll start crying again if I think too much about George too. But so once I got out there, I realized I couldn't just make this an amateur sociological experiment or a classroom, but I had to begin providing medical care because I saw people with maggots in their legs and wounds and central lines that were still in them, and then the unseen wounds of repeated rapes and trauma and childhood conditions and mental illness and addiction and all the things that go with losing out on the game of life. And so I began to just build a backpack. The street taught me what to put in it, and the streets continue to teach us everything, hopefully, that street medicine is about. If it isn't accountable to the folks on the street, if it doesn't serve them, then it's BS. And that goes all the way up to advanced programs that we develop. So accountability to the reality of people on the street is one of our absolute intentional core imperatives. If we get a grant that takes us off in a different direction, we keep a really close eye on whether it's causing mission drift, or as I like to call it, a retreat from the street. And so I began to get other volunteers. Here we are helping a fellow, Mikey, who's amputated 4 feet, kept getting reinfected. A lot of hospital costs associated with just his care. And we began to do what I call chase management. And we followed him around and we got his wounds to finally heal up, and we saved the hospital hundreds of thousands of dollars in 6 week antibiotic stays, et cetera, et cetera. Carol, my first nurse, again with that same natural body language here with Frank. And we began to realize that we were entering into sacred ground here that really required us to stretch ourselves and evolve to transcend a lot of the thinking and the relationship building. And all the volunteers and staff involved in this have fiercely hung on to the work because we get so much out of the ability to be there for folks and let them share their lives with us. Here I am actually writing a note, I think, under a bridge for a guy to reestablish care with his primary care physician. I'm writing, Larry, Dr. Jones said he misses you and will be happy to see you Thursday at 2:00. And so I realized, oh my gosh, we're becoming home care service for folks under the bridge. The bridge in the background symbolizing the connection between those two worlds, if you will. And around this time, I had this, one of the epiphanies of this journey is that it was like imagining a fire department for the first time. And I thought, oh my gosh, every city that has people living outside, if they can have a program like this, it's so strategic and so powerful. Every community should have one. And I began to think in those terms. We were able to get some grants. We got an office. Kenny here had a lot of traumatic brain injuries, and he could find his way to our office, and he knew he could trust us. We're giving him a belt because people donate pants without belts. And so we just, again, try to replicate the sense that we have on the streets of grace and respect and all those values, but moving upstream a little bit, making that interface the same, where people begin to engage more with the system. And that's a real art form. That liminal relationship building can be very, very interesting. I was able to get a grant to get my program started, and this is Operation Safety Net, as we were back in the early 90s. 3 of those gentlemen experienced homelessness, social work, a nurse, and an incredible administrator that helped us put things together. We began to realize that the more services we could bring directly to people, Melody here is helping this woman with housing applications. The more you could bring to them, the more it actually worked. You've heard of housing first. Well, this is kind of like relationship first or care first. And it just makes so much sense when you see the value of not waiting for someone to show up at your office or your little booth, but going and finding them and saying, hey, what's up? Yesterday, one of the patients that I work with, we came into the camp and she was shooting up IV drug use, and she was upset because we always showed up at the wrong time. But we went to work with someone else for a little bit, and then she came out and she gave us a big hug and she was grateful. That's the kind of relationship that really means something to folks and to us too, is that we don't have to get into the blame game or the judgment game, which you're almost forced into when you get into structures. It's been so fun to innovate. This was our early version of our electronic records system. And we began to do more procedures. This is an abscess drain one of my residents is doing in the field. And then you begin to see the contact points with the system. There's a lot of stuff on this slide. I'm just going to go to the emergency room utilization is out of control with people rough sleeping. The bottom is my hospital. I looked at our complex care committee. I was on it, and I saw that 64 of the people that are using the emergency room the most, 34% of them were living on our streets. And so we used that information to build deeper relationship with our hospital, and it resulted in many, many good things: respite care, probably our fellowship, and other things. One of the core principles, and we're kind of calling it a continuous care model, it's kind of the medical home on steroids, because wherever someone goes, we go there. And if they succeed with housing, we celebrate it. If they say, screw this, and they're back under the bridge, we go there. And there's something about the sum of all those contact points with the same value system that is way more than any individual window on the person's healing journey. That would be a great discussion. You know, what is healing? How does it happen? It's far, far more than motivational interviewing, but it is grounded in some of the same values, the same values that Di Clemente and Prochaska and Clemente, envisioned. One of the key things then is you find these win-win-win-win places. And I began doing street medicine consults. And I realized that it was such a socially important place to humanize the person served and also humanize the staff to each other. And this is one of our most critical roles, I think, and why hospitals should pay us more. But good studies now have shown that This decreases the readmission rates, the length of stay in the hospital, and ER utilization. And most importantly, it just is reality-based. I wrote an article on reality-based healthcare because I think that's one of the kind of core concepts, is that if you can deal with you can base your healthcare on billing, you can base it on what you're set up to do, you can base it on who you like to serve or who's convenient. But we ought to explore the notion that reality is really kind of important. We were willing to, not enough, invest in that by developing geriatrics and other kinds of things. But the less people are valued, the less likely it is for us to provide the kind of concierge medicine that we do for folks. I'm proud to do. This is a bad discharge plan. We've done so many other things, and there are stages of development of street medicine programs. I can mentor you all through it if you're interested in creating one or improving a street medicine program. But when the tree grows, you begin to naturally do things like respite care models and winter shelters and other things, which save lives. I believe heavily in students. I don't believe in lots of them. I believe in the ones that really are passionate and need to be validated in that passion, but then can also learn to learn from reality, from the people that are excluded. And most of the street medicine movement, I would say probably over half, globally has been due to student leadership, growing up, creating their own street medicine programs, their own departments of street psychiatry, their own, all kinds of amazing things. It's a fluid classroom. Written an article or two on that as well. I do think that these same principles can be applied to many other excluded populations and settings. And that's why, the care that you guys give is very familiar to me. I think we're if not sisters or brothers, we're definitely cousins. Dr. Torres Sanchez in Puerto Rico did her doctoral thesis on the value of the street classroom. I love how she connected it with social justice. But again, it's highly rewarding, and over the long term, it's made a huge impact and has helped create the field. These are some of the many health science schools that are doing street medicine. I won't get into this, but if you can connect housing with your street medicine program, I think the penetrance into the population is much deeper than most housing programs, because it's basically the nurses and doctors and people that have been there for you in a snowstorm, and being a conduit into housing is really powerful. But not everybody makes it. And this was Froggy. I took a picture of Froggy because I just felt like we weren't going to have him around much longer. In fact, he did pass away not long after this. And I began to have this ball of grief and ball of anger because of the way that no one was mourning our sisters and brothers on the streets. And it was just getting to be too much. The mortality rates of those experiencing homelessness are about three times the normal population, or housed population, I should say. Gotta watch my language. But those living rough, sleeping rough out on the street, the unsheltered, have a 10 to 12 times mortality rate of the general population. Leave it to Boston to do this, the good studies. But this was Bill, and Bill was in front of my office, our clinic there, and visiting for some reason. And I said, Bill, can I take your picture? And Bill said, nah, I don't think so. And I said, it's okay. I won't, I wouldn't use it without your permission. He said, well, that's not the problem. I've been in your office and everybody on the wall is dead. And it hit me. And we talked for a while, and finally he said, well, you can go ahead and take a picture. And then the week after I took this picture, Bill passed away from complications of his long struggles. And it really, really haunted me again. angered me. And so I think in '96, the writer Sidney Sheldon sent me a letter and a check. He said, "You should be cloned," and he had $1,000 check in my name. And I said to Mike, I think we should buy plaques, and we'll put them wherever someone died. And we don't care where it is, if it's next to City Hall or under a bridge. So we went to do that, and then the police pointed out that you're not allowed to do that. So I went to the mayor's office, and he said, "Well, we'll give you a wall. You can put them on a wall." And I said, "That's actually a really good idea." So we have a memorial wall. Unfortunately, it has more plaques now than this, but it's a place where really sacred ground. Sadly, this is the picture of Tracy, who was there with a little girl, and this is Bill himself. And we memorialized people who otherwise would have been forgotten. Some of the names up there are unknown. We could not figure out whose body it was, but it means a lot to the people on the street because they'll leave flowers and things, and they attend the annual Homeless Memorial Day. More and more, the audience is filled with people from the campsites needing to share and think about the ones they lost. This is one encampment of people that saw their friend Boston's plaque, and immediately they all put their hands on his plaque and started crying. That was a powerful moment. The sad postscript to this is I think every hand there is now also gone. It's a dangerous zone. I don't know if because I'm not keeping track of time, how I'm doing for time. I could end there, or I could talk about the global movement.
Dr. Withers, you still have about 30 minutes if you want to keep going for a while.
All right. I'm going to enjoy this then. All right. Thank you. And so when you're doing something significant, and I usually say this to folks earlier in their career when they're all ready to take on the world and try to do something that is meaningful. I always connect it kind of with The Hobbit, or something that is a Joseph Campbell kind of a quest. Not that you're the hero, but you're definitely the protagonist of your own journey. And there's books like My Own Country by Abraham Verghese that I always recommend, in which someone was within the system. In Dr. Verghese's case, he was an ID doctor in rural Tennessee at the very beginning of the HIV epidemic, and I was an intern back then. And I remember the terrible way that society and healthcare, large parts of healthcare, responded. Nobody would draw bloods or put IVs in those patients in my hospital. So the interns we had to all learn and do at the same time. And I remember being kind of terrified of that. And also it began to feed a deeper sense of I'm at a really important time to be there for people that everybody else is turning their back on. And that became a lot of sort of the sense of why I had went into healthcare and why I was doing it. And so I've lost track now, but I think it's really important to try to find folks in your tribe, people who care, and it can be folks that aren't even in healthcare, but share that sense of wanting to be human to each other and to people that are tossed aside. And don't let the hidden curriculum, as they call it, of healthcare. These people aren't like us. They're dangerous. They're dirty. They'll sue you. You'll shoot your eye out. Whatever else people say. There's never been anyone so far ever hurt doing street medicine by a person served. And if you think of one ER, that's just incredible. That p-value is not even there. And no one's ever been sued, certainly not successfully. We had our law department here and our surveys within our movement kind of validate both of those facts. those are things that ought to be investigated, because someone should have been slugged by now, or there's, I hate to say it, but it's the world. And yet that's the kind of relationships that are out there. And I'll bet you my dad never got sued by anyone. He did house calls on. I don't think he ever got sued, actually. But and so I needed to find somebody else doing this work, but I didn't. For the first 2 years, I'd never heard of any healthcare person going under bridges. There were nurses that I later learned. They usually called themselves rogue nurses in Chicago and Cleveland, and a great group in Toronto. But they were going out, almost getting fired by their FQHCs, who otherwise were doing great work. But as far as an organized practice, I'd never heard of it. Jim O'Connell had been doing the work about 6 years before me, and Joe Greer in Miami, and Dr. Riley, a psychiatrist also in Boston. But otherwise, it was not a thing. It wasn't really considered part of normal healthcare for the homeless. I happened to be in India in December of '93, and I heard about a doctor in Calcutta then, who was doing work on the streets like I was, and so I traveled from South India up to Calcutta, and introduced myself to Dr. Prager, Jack. He is a wonderful human being, humble as they get, and dedicated and good. His story to getting on the street involved caring for people, but then getting in trouble by investigating the abduction of young children, especially girls, into sex trafficking. And he got into trouble by not giving up on pursuing that. And they kicked him out of Bangladesh. He went to Calcutta and continued to work on the issue, and they threatened him and threw him in jail. And finally, when he got out, they told him he couldn't have an office. So he started working under the Howrah Bridge in Calcutta. And he did work on the street from 1979 until about maybe 5 years ago. And it was a revelation to see someone from the same planet that I was on. And that affirmation that I wasn't crazy, that this was a thing that could happen, it led me to recognize, even though the faces and the situations are different, the bones, if you will, of the practice were the same, identically almost. And so I realized that this should really be in every city. And that's when I began really becoming determined, if you will, to be an evangelist, as I'm trying to be a little bit today, for the practice that brings care to people rough sleeping. And so I began to find a few folks like Jim O'Connell, but then I mostly began to, oops, that was a jump. Well, okay. All my international slides are out of this picture, but I began to travel, to give lectures, to help communities set up street medicine programs. But I didn't call it street medicine until 2003 or 4, when I got another grant to replicate my model. And I said, it's not McDonald's at this point. Can I just have a symposium where I gather the people that are dedicated to this work and who are actually doing it? And so we had our first international meeting in Pittsburgh, and I had to give the symposium a name. So I called it Street Medicine. And that's where the name Street Medicine came from, because I just needed a name to describe the activity. And it was one of my Forrest Gump greatest things, because it's now being used on every continent. We do have an annual symposium. These are the locations of the symposia that we've had. Not yet any in the Global South, but I'm working very hard to make that happen. We have partners in the Global South, but not enough. And then this coming fall, fellowship. These are all out of order. We started the world's first street medicine fellowship. Denise, Dr. Cole here, was our first fellow. And our most recent, yeah, I don't mean to diss Ella here, but she's doing ER medicine now. But my most recent fellow, Eddie, is running a multi-systems emergency departments, doing social determinants of health and street medicine. And Denise is an adjunct member of our board and the head of our educators coalition, and also has set up street-based programs in Milwaukee. This is roughly our network. I've heard that this is way out of date, and we have a group of students that are collating that. And then to pull it together, a number of us launched the Street Medicine Institute as a separate nonprofit. It became official in 2009. This is that symbol of the person respecting and touching the people that we serve. Yeah, there's our next. If I can tempt you all, our next symposium is in Hilo, Hawaii, in September. I always have to give credit to the nuns, the Sisters of Mercy, who have done this work. The Walking Sisters of Pittsburgh back in 1843, and have been supportive of my work. And that's our website. And Lois says thank you, and so do I. And I'd be happy if, hopefully that kind of was appropriate for the event. I do feel I'm fascinated to learn more about what your work is, and maybe to learn from each other. Thank you.
Dr. Withers, thank you so much for that incredible talk. I'm just touched. As a physician who cares for patients, and I've been doing so for 14 years, I deeply believe that our patients are our teachers. And I really love the way you grounded this talk in the stories of your patients. And so thank you for sharing those stories. It's deeply inspiring. We have some questions for you. And so I'd like to get started if you're all ready for that. Your thumbs up, we got it. Okay. And some coffee. There you go. So a lot of questions here. And I have some that I have myself, but I'm going to start with the first one here that I see. And it's about how can community health organizations measure the impact of mobile health interventions on community health outcomes?
Yeah. Where's Brett? I'm not smart. I'm not smart, but I got smart friends. I think within the street medicine movement as well, it's even a little harder maybe because of you're building the infrastructure to do the care, and it's very, very difficult. You probably have the same experience to build the superstructure to measure it and not lose your energy to actually care for the people. But in street medicine, at least, we do count the number of people that didn't. I remember my first grant was just my notes. The first 119 patients that I saw, I could just see how many of them didn't have insurance, how many chronic illnesses that weren't being treated, and some of those illnesses, and just the demographics and the basic stuff. The interesting thing is pretty much anything that you would study in street medicine is publishable because it hasn't been measured or done. So that's the intimidating part of creating a new infrastructure, but also the opportunities that are really important. As far as utilization and cost savings, we're always a little leery about that being the motive, but you have to speak to that, and it is very important. And for that, there are people at the Institute who have done really clever and good work in that regard. If anyone really wants to pursue that question, particularly Brett Feldman in USC in Los Angeles. He's definitely the West Coast leader of street medicine, and Jim O'Connell, and some work in Texas as well. We're actually beginning to do key performance indicators. It's kind of like harnessing a wild horse to get us all to do that, but we're getting there, and we understand the importance of it. So we've developed, those things that we feel are important, but also very much aligned with what we actually do. So I'm going to beg off further depth of that, because I think I'm out of my league a little bit.
So I am going to veer too, because that's actually a little bit, I'm really interested, Dr. Withers, and as you know, Virginia Garcia has a long history of providing mobile care to our migrant and seasonal farm workers, and we've been doing that for a long time. And as we begin to see the needs in our community change, we are wanting and we are looking to expand our mobile health program. And I know that for many people, they say, getting care in a mobile van is still not quite the same as seeing somebody out under the bridge, but I know that many of the principles are the same. And so my question to you is, if you have any tips as we begin to grow our mobile program here at Virginia Garcia, do you have any key strategies that will help us build a coordinated program and a sustainable program? And when I think about coordinated mobile health program, I'm thinking that there's the clinical care, right? But there's also pulling in the social services, addiction, housing. You touched on some of that. And so any tips on how we could do that, launch this sustainable and coordinated program?
I need to come hang out with you some to
I would
really
love that.
to get a sense of the context, because there's a growing number of people that are joining the Street Medicine Institute as members that are way more in your kind of settings, which are more less urban and probably more mobile for sure, and probably more cultural. I always find the cultural threads really fascinating. Those communities around the world actually that work with indigenous people have a lot of lessons that we could learn from in Anchorage and Minneapolis and Copenhagen and other places where there are indigenous people. There's stuff that you understand. I'm like the beginner here, but there needs to be a lot of time spent to honor and understand and listen to the natural leaders, get to know the language, have representation in within your team. It's always good to have to be very doctorally about it. Lots of receptors that can be attached to a menu of folks is the best, genders, races, etc. And start small. I used to give a lecture, I still do, I make an analogy of starting a street medicine program to starting a campfire. You can get the manual from us on fire building, which might help, but you can also, learn from those who have just learned it. But it always involves planning as much as you can plan, but then not getting wedded to your plans. But, educate yourself, because you can gather your tinder and your logs and clear your space and for the fire, but then you have to start with a tinder and really respect the fact that this, important things have to be started with great sense of sacredness and care and respect. And, to march out there and take over the streets, you can do stuff, maybe deliver more blankets and stuff, which does good, but it isn't the same as building the relationship. That's really, really the essence of it. And so you find community health workers or people who from the community to guide you. And then those identified organizations that are doing similar work, go introduce yourselves, ask them what they do, respect them, always have, even to the police, ask them what they're experiencing, maybe especially the police. But you need to know the people that affect the people that you love. And I learned the hard way that you can't just love folks that are marginalized. You just turn into Che Guevara, and you do more damage when you come back into the system with your angry fists and your vengeance. You have to kind of listen and respect and build partnerships that are going to work for those human beings that are stuck in structurally violent systems that can really do the things that need to be done. So it's ultimately community building, and everyone should be part of it. And the principles of community building are just natural stuff, like just respect, not assumptions, not stigma about who the person is that you're talking to. And as you gather more and more of a collective people that just get that, then your social sense of who's an asshole and who isn't, it gets very organic. And then you get a deeper sense of not, it's not your own personal crusade you're on or something. It's something way deeper that has to do with your humanity and the humanity of the people you're serving. So that's another one of those deep dives. But I'd say then as your Tinder starts going, maybe in a one area or one arena, then you'd be able to throw some twigs on it and grow. Like, we didn't go into the Hill District, which is an African-American population, most of the people living in abandoned buildings, for several years until we got the partnerships. I used to go into some of the shooting galleries and crack houses, which we realized was not a good idea. And so we adopted, and we had our first mobile van that we parked up there, and then people could come. And so the fundamentalists of street medicine that don't think vans have a place, I disagree with them. I do think that there's something about, having a door you have to come through is too much for some people. But the can't think of good words. The ecosystem of the street environment requires many doors and many options for people. And there, as you guys know better than me, there's community that builds around your van. There are people with experience that, and volunteers and people that aren't inclined to crawl under a bridge, that have great things to offer. And you can have more services, and you don't have to go to McDonald's bathroom to do that exam, all that kind of stuff. So I didn't answer the sustainable part, but I do think that as you learn who there's a thing I call in-reach, and I won't go into it, but it's a principle of moving into the system from the street, and it involves you collaborate, you advocate, you innovate, you integrate, and you celebrate. And we can talk about it, but it naturally, organically becomes an advocacy model, and you find out the people that you need to use to work with. And then you make partnerships collaboratively, and those grants build. And because you're strategically located, they want to work with you. You become the belle of the ball many times. Everyone is willing to do grant work with you because you're scratching an itch that they can't. And so that way you can build a sustainable, at least grant structure. As far as billing and other things, that's another topic we could talk about, but there are much higher levels of sustainability for street medicine. I would say the best answer is streetmedicine.org. And we have all the services. A lot of it we provide for just free because we love you. But you can apply for the seed grant, and then we would, like in Bend, Oregon, and we really we come there, you go somewhere else. We really get deep.
Thank you so much, Dr. Withers. And speaking, you mentioned grants. And what about, do you know if there are any specific funding opportunities that are available for community health organizations to develop and deploy mobile health initiatives? Or is this really more specific or local, or how could we learn more about that?
Yeah, I mean, I think everywhere I've helped seed a street medicine program, not everywhere, but a lot of those places, they said, can you come to our annual, giant organizations, parent organizations, annual gala event? We are getting the award. So, street medicine is something that symbolizes something maybe way more than it should. We get more attention maybe than other groups doing good work, but it is a very visual and dramatic thing that does galvanize. And so locally, there are pathways that lead to, if you're respectful and you do it well, to a really good positioning of your organization by having street medicine. You'll be very sexy. But at higher levels, and that often is through your relationship to your continuum of care and politicians, then you can get regional and state grants. And we were getting most of our funds from HUD for a long time. We housed thousands of people that way. Increasingly, I don't know now with this administration, but at the end of the last administration, suddenly there was these grants. They're huge grants with the name street medicine on it, which blew my mind, for HIV, for medical education. And so I'm hoping that we can keep under that radar, and there'll be more awareness of the value of it. You can bill for it. We never were able to bill until October of 23, and that's advocacy that we all did. But I give Brett credit in California. Medicaid, Medicare, Center for Medicaid and Medicare first allowed billing after some agitation in California. Then my governor did it in Texas and Hawaii, and then nationally they allowed it to be a billable service. Never was.
Great. There's some really good comments, and I'm loving the comments about building trust. And somebody said about how the actual medicine part is really a small part of it, and it's really about building trust with partners. So absolutely agree. We also had somebody talk about the importance of the cultural and linguistic appropriateness, which you touched on, and absolutely that is something that we really truly believe here in Virginia Garcia. I really think, there's another question here in the chat that I'd like to read and give to you, because I was thinking about this as you were talking. We at Virginia Garcia are proud, we do primary care. We believe that at the end of the day, primary care is the best healthcare, but understand that not everybody can get into primary care or is not willing to go into primary care. But our Gil Munoz, our CEO, is asked, how has street medicine enabled individuals to connect with primary care or even hospital services? Can you talk about that a little bit?
Yes. It takes a while. Some folks, you give them a card and they say, wow, will you be there? Because I'll go if someone like you is there. And then you make the connection. It's as simple as that. There are other folks that really need navigation, and that is a whole limb of your program. I'm sure you do this too. Mm-hmm. And so that's important to have that, to understand that navigation is there. I don't know how much time we have. I'll tell you a really quick story. So I realized at one point, I still am a clinic doctor in our hospital, and someone would come in and they say, Mr. Jones is here. He's homeless and he smells bad and he's drunk and he's an hour late. Can I call security? And I might have said, oh, okay, we got to get on with our day. And then after I really got involved with street medicine, they came in the same story, and I said, is that Bobby? Well, yes, Robert. And so I'd run out, I'd give him a huge hug. I'd say, Bobby, you're drunk, you smell bad, you're an hour late, but you're here and I'm so proud of you. I know how hard this was. Let's get a cup of coffee and reschedule. And I'm the same preceptor, but man, I looked at things differently. And so that navigation stuff is a challenge. I won't get too deeply into the debate, but Brett Feldman said it for all of us at one point. He said, the best medicine, best healthcare is the healthcare you actually get. And a place like Los Angeles, that may be only on the street, but I have watched and encouraged, and I wish I had more numbers in my hand, but I do know that we have an integrated primary care clinic in our health system, embedded in a behavioral system. And so we have harm reduction, peer support, we have psychiatry and family medicine co-located. And that is a great target. And the providers are all, congruent and peers. So I also believe that primary care is really best done in a really good setting. We got qualified as a medical home model recently, but I know that we are able to over time get people not just into primary care, but into housing and other services that they need. But it's that irony of people only being able to envision that if you don't make it the requirement for the relationship.
Mhm.
Kind of funny.
That really resonates in the summertime when we are out at our migrant camps and in our nurseries. Many of the patients that we see, once they make a connection with one of the providers, then they're willing to come into the clinic. But going back to the navigation piece, right? There also is the transportation, and there's other barriers, and so we are also able to help them with that. But there are so many different pieces to get people into the clinic. But it's good to hear that, like you said, that connection and that trust, I think you said earlier in your talk, relationships first, care second. And I think that's one of the themes that I'm hearing from your talk today, Dr. Withers. I wanted to switch to a question that we have here in the chat. And it's a great question. It really speaks a lot it's a question that I think we've been thinking about a lot here at Virginia Garcia, given the political climate. And one of the questions is how do these concepts of home health care or healthcare in the streets be applied to VG patients or Virginia Garcia patients right now, when many patients might be afraid to leave their homes in the climate of potential ICE deportation? So can you talk about that a little bit?
Well, we're not in the crosshairs as like you guys, but we are providing educational materials to all the organizations on what to do if that event happens, and know your rights, and don't just cave, and make sure that people that we serve know their rights, and that give them ways to get quick support and legal backup. So it's good to have, you probably have, legal partners that can come, jump in as almost the same spirit as us. So the ICE question, but there's something deep there that I'm not quite hearing.
So I think what I'm understanding is that many of our patients right now are concerned about going into hospitals or clinics.
Oh.
Concerns that we could have people who ICE agents might be in the clinic, and during this climate where we know that hospitals, churches, schools are no longer considered safe zones, that is a policy that was rescinded with the new administration, and I think there's some fear. And so wondering if some of these concepts might be we could use some of these concepts now. Do you have any thoughts on that?
Yeah, I mean, most of our work, we do interface all over with organizations, clinics, agencies, everything. But we really do focus on the realm of the streets.
Mhm.
But there are relationships. There's a Birmingham clinic, it's called. It was started by one of my first residents. And it requires you not to have insurance. There's lots of advocacy there. There's another, Casa San Jose is really good too, but Birmingham Clinic is it's very clear that, it's a safe place to come. And if one of us accompanies someone there, they'll immediately get that. So I think you have to kind of find collaborators and make sure they're trustworthy. And then it's almost like the Underground Railroad, railway in some senses, but it's all about knowing that your what you say is safe and true, and then navigating through trust people through those services. But there are big gaps. There'll be big gaps, and then you have to fill them out in unconventional ways, places, and just do the right thing. Do the right thing till you get caught.
Dr. Withers, we have a few more questions. So one of the questions that somebody posted was if you could talk about some significant trends in mobile health that you have observed in the US over the past year.
Yeah. I've had 3 mobile units. My favorite was our little bread truck, the first one. It was so mobile and just had a coffee pot and a little place to sit and little sliding door. And some of the best moments I've ever had were in that little unit. We could park it. We could scoot away if we had to. But then we got bigger mobile homes and bigger problems. I know you guys are probably a member of it. There was a big mobile health convention here in Pittsburgh. Some of the Puerto Rican colleagues came up from there. But are you a member of that National Mobile Health Organization? Yeah. Okay. So you know more than I do. I do think that the interface between street medicine and mobile health is very natural, but a little bit surprisingly rare. Sometimes I think we get too snobby about our street work, and we, are addicted to it. And I do think that just like harm reduction and all the others, you become fiercely wedded to your model, which is important and working, and then you don't really have peripheral vision for the partnerships that you need. Trends. I'm blanking, sorry.
Dr. Withers, I have a question, and this is something that I was just thinking about as you were talking about, the trust, and we've been talking about the trauma that our patients face either when on the street or when they come into clinic. And many of those stories, our patients share those with us. And I know that for some providers, there could be this sense of maybe overwhelm, sometimes vicarious trauma by clinical staff as they begin to, because again, hearing a story in the clinic, I think is very different than hearing a story under a bridge or in that patient's environment. And I wonder if you have any strategies or what your thoughts are about how to avoid overwhelm or this vicarious trauma with clinical staff. And I'm thinking about our group here as we begin to go into these different environments and meet people from different communities who have some really traumatic stories. How can we help our clinical staff from maybe avoiding some of that overwhelm?
So you're referring to in the health center or the clinic as well?
Well, as we look at expanding our program, do you think that there are some strategies?
Yeah, that's such a huge and wonderful area to bring up. Even within a street medicine program, there can be a sort of a drift between the folks that are indoors doing all the work and people that are in the bridges, and then there's misunderstanding and assumptions, and it takes constant refreshing. We try to rotate people in the office out under the bridges safely with people that are not going to expose them to stuff that they can't process. We have safety protocols. We say, I think I got something in my eye, and then everyone kind of backs away to look at their eye, and we get out. But and then a really important part, you probably guys do it maybe too, but it's the reflective component afterward to process. not just what you saw, but like how it affects your existential understanding of yourself, the universe, and everything. Because you need that processing when you're coming between these different realities, especially the realities of, some of the places that we go. I remember in Puerto Rico, we took 50 some people in Iniciativa Comunitaria that hosted, and it was too much. We took, I think, 50 some people into shooting galleries, active shooting galleries with experienced people in small groups at many locations. They have a big program. You guys might want to look at them. But we came back and realized that even I was kind of overwhelmed by what I saw. And so we had a really, really important debriefing session about it. So debriefing, kind of, I did a lecture with my nurse practitioner on, like, I called it Doctors Without Boundaries. And it was kind of like, what's the new normal? You understand professional guidelines and boundaries, in systems, but then do you throw those away? No, you have to develop something. Basically, you have values that drive what you do, but then you do have to get together and understand what's normal and what's too much. So I do think rotating people out there is important, articulating it. We do in-services. We celebrate successes, not enough, but I think it's really important because so many people just see hopelessness and they don't get the rest of the story. Like ER people don't get the rest of the story. And so you have to be sensitive to that. I think a chance to explore, I don't know if I think this morning I told this story, but I gave a lecture, used to give a lecture every year in Santa Barbara, and a paramedic came up in her outfit and she said, see my slides. And she said, I think I want to work with this group. And I said, that's great, because we don't get too many first responders. And she said, well, I want you to know I hate the homeless. I can't stand them. We're out there, they're MFing me. We're just trying to help them, taking a swing at me, sexual stuff. And someone spit right in my face. She said, I hate them. I thought, I like this girl. She is honest. And I remember being trapped in those feelings. She recognized that she was trapped. And then she said, I want to work with them like you do. And so she was liberating herself. She was imagining herself liberated from that setting. I came back later in the summer and she went on rounds. She ran out with her volunteer t-shirt, gave me a big hug. She says, I love these people. And it's the same person. And she said, but most of the paramedics are really pissed at me now because I'm working with these people. She said, but there's one guy, he was a medic in Afghanistan, and he's really interested, so he might join us too. And that was just a story that kind of explored the different views of the same shared city that they were in. And so people need that space to reimagine and understand people. If they're not willing, then put them somewhere else. But if they're curious and they deserve to be heard as to being spit in the face or they treat me, and you have to be really careful with the people that are at the front door. Mm-hmm. Because folks come in, they are not ready for prime time. And if you subject some poor person or two all the time to the complaint department, that's not fair and it's dysfunctional. And so you have to give special attention to them, honor them, engage them in some of the work, and then rotate them a bit, because they're like strapped to the front of an icebreaker, and that's not fair.
Thank you so much. I think that is really helpful. There's so much enthusiasm and for that work, but I can see how it can become overwhelming. And what I'm hearing is that space for processing, for debriefing is really important. And I was taking notes as you were saying that, because I think that's something that I hope that we'll explore as our program expands.
We have to stay in touch.
We do, Dr. Withers, most
We're family.
definitely.
We're family now. You
I
can't-
agree. And like I said, I just got the message that we are almost out of time. I think we have time for one last question, and then we will go to our closing remarks. So the last question, I was hoping you could tell us about what you see as the future of mobile health in the next 5 to 10 years. That's a big question, but love to hear what your thoughts are.
Yeah, again, I'm adjacent, but I do feel that looking at the hospital centered journey we've been on, more procedures, more billing, more specialty, more centralized, more excluding, that is kind of getting to the point where something has to happen. And I think, I don't know the accountability for that, but I do know that going to the people the way you guys do, and it could be the rich people, we have to get out of this factory system. And I think that you guys are right positioned to understand that journey, and the ways to get there. So I do feel that we're both we're a little fringy, but we're both definitely in the forefront of where healthcare is going.
Thank you so much, Dr. Withers. I have really just inspired, and like I said, I'm looking forward to connecting and learning from you as our program grows and expands. I think looks like that was for questions. I think we are done. So I am going to I want to thank you personally so much for everything you've shared. And I'm passing the baton off to Stephanie Caballero so that she can give some closing remarks.
Thank you so much, Dr. Galvez. Good afternoon, everyone. It's great to be here with all of you virtually. My name is Stephanie Caballero, and I'm the Executive Director at Virginia Garcia Memorial Foundation. And we appreciate you taking the time to join us here for this rich and important discussion. Thank you so much for being here with us. And of course, many of you here, I've seen it on the chat, Varian, nice to see you, as well as other partners. We know that mobile health and street medicine are not simple innovations. They are lifelines, as Dr. Withers shared for many of our patients that we serve, and he had great stories of some of the patients that he has been able to serve over the course of his time in street medicine. And many of those patients we know have many barriers to accessing and traumas to accessing traditional healthcare setting. And so for us in our work, it really encourages us and challenges our creative thinking and ability to think of innovative ways to bring care to those who need it, no matter where they are. And it helps us ensure that we can think about ways to deliver that care that is built on trust, mobility, and deep respect. I really heard that through your presentation, Dr. Withers. So thank you for reminding us of that. Deep respect for the lived experiences of those that we are serving, and being able to meet people where they are, because that is crucial to establishing that trust and to ensuring that we can see the individuals for who they are. And hopefully today's conversation really helped many of you think of ways that you can embed that into your mobile health program, whether it is that we're bringing services to somebody on a sidewalk or who is living at a shelter and a mobile unit like many of us operate. That is parked outside their community or another clinic. We want to make sure that we consider the many ways in which our patients and those that we're serving require our programs to be flexible, creative, and are built on strong partnerships so that we can partner with others who, like Dr. Withers mentioned, are trusted and partners and our allies in the work, because that is what's going to help us be more successful in the delivery of care. and it will demand investments, and it will demand staffing, infrastructure, and continuing to expand and build new relationships so that no one is left behind in our community, especially at times like this. This year, as Gil mentioned, Virginia Garcia is celebrating 50 years of impact, 50 years of service, and we remain committed to continuing to remove barriers to access and to expand care and to bring compassion and dignity to the services we are bringing, no matter where they take place. Again, we hope that today's discussion brought valuable insights, and you can think of new strategies, and you found some inspiration to strengthen your own mobile health, street medicine, or any type of program that takes place outside of the traditional walls of our healthcare setting. We really hope that we can all continue to work in partnership to advance health equity in every corner of our community. Today, I also want to invite you to support, if you are able to, Virginia Garcia's mobile health programs. Your generosity today is going to help us expand our program to help us reach more community members right where they are, so that no one has to go without the care they need and deserve. You can scan the QR code on the screen here to support Virginia Garcia in our mobile health programs today. Before we part, I want to take a moment to give special thanks to our moderator, our wonderful Dr. Eva Galvez, for doing a fantastic job this afternoon. Thank you so much, Dr. Galvez. We appreciate you. And so much gratitude to our keynote speaker, Dr. Jim Withers. I know you are a very busy person, and many of us who are familiar with your work know that you have many of these commitments, and we are truly grateful that you were able to take the time to join us, share insights, share important experiences of those that you have served over the time at the Street Medicine Institute. And we look forward to being able to bring you back to Portland and to continue partnering with you. Thank you for being here. And of course, last but certainly not least, I want to take a moment to thank all of the partners who helped make this afternoon possible. Your support makes it possible for us to host this event free of charge for anybody who would like to join us. To our presenting sponsor, the CHP Group, thank you for your many years of partnership. Thank you for being a key supporter of this event. To our annual partners, A2C Wineworks, Care Oregon, Legacy Health, Linguava Interpreters, and McDonald Zaring Insurance. To our helper sponsors, Kaiser Permanente. And to our friend sponsors that you see on the screen, as well as our ally sponsors. Thank you all for making this event possible. This concludes our 2025 Virtual Healthcare Symposium. You will be receiving a recording sometime next week. Thank you again for joining us. Be well.